My name is Nicholas Merritt, and I'm a student in Indiana State University's Doctorate of Athletic Training program. This presentation will encompass the concept of neurodynamics, including biomechanical properties of nerves, and limb tension tests to evaluate those nerves. Peripheral axons are distant from their cell bodies. They are bundled together by a sheath to form a nerve fascicle, and several fascicles are held together by epineural tissue to form a nerve. Layers of collagen and perineurium surround the individual fascicles and collectively provide mechanical strength. The perineurium is the primary load-bearing portion of the nerve. The epineurium is loosely attached to the perineurium, surrounding each individual fascicle. This loose attachment allows for gliding of one fascicle independently from the others. This epineural connective tissue helps disperse compressive forces. When a nerve is elongated, it glides toward a moving point, also known as convergence. If the tension of the nerve is relieved during joint motion, the nerve will move away from the moving joint. This is known as divergence. This elongation of the nerve causes an increase in nerve strain, which is the highest in the nerve segment closest to the moving joint. When a load is first applied to a resting nerve, the nerve lengthens to accept the applied load. As the tension increases, the nerve elongates at a steady rate. When a nerve is placed under tension for a fixed period of time, there is a reduction in the tension of the nerve due to a relaxation effect. Stress relaxation in nerves that are stretched slowly is greater in nerves that are stretched rapidly. Tension applied repetitively causes a reduction in strain due to decreased stiffness. At a certain point, the amount of applied load starts to permanently deform parts of the nerve. Eventually, the nerve reaches its ultimate elongation and undergoes mechanical failure. Nerve tension can be described simply using the example of the ulnar nerve. When the shoulder is in 90 degrees of abduction and 90 degrees external rotation, and the wrist is at neutral, then the elbow is moved from 90 degrees of flexion into full extension, and the ulnar nerve is shortened and the tensile stress on the nerve is decreased, diverting the nerve away from the elbow. In this position, when the wrist is extended from neutral to full extension, the ulnar nerve is lengthened and the nerve converges on the wrist, causing an increase in nerve strain. The intensity of the nerve strain will be greatest at the wrist, and the fascicles of the nerve will glide independently. The magnitude of these factors will depend on the rate of limb motion, time spent in elongation, and if the motion is repetitive. When a tension test is positive, it is not an indicator of nerve damage or spinal disorder, but an indication of mechanical tension somewhere in the nervous system, although you can't rule out that there is a pathology suspected. It is possible that a pre-existing condition in the spine can cause secondary disorders in the peripheral nervous system. For example, if a patient with carpal tunnel syndrome presents with neural lesions on the brachial plexus, one could be causing the other, or vice versa. The true implications of adverse mechanical tension are continuing to be studied. Structural differentiation, meaning determining a difference between neurodynamic response and the musculoskeletal response, is an interesting topic that has been studied by Shacklock. Shacklock found that the musculoskeletal responses stay the same with changes in movement, while neurodynamic responses are present when symptoms, range of motion, or resistance to movement changes during structural differentiation. Essentially, symptoms are thought to be produced solely due to the tension on the neural tissues, rather than musculoskeletal tissues, if the symptoms are produced by a positive test, and then they're relieved by a structural differentiation, or the returning of the stretched limb to a neutral position. Shacklock states that an apparent abnormal neurodynamic response occurs when structural differentiation causes a reproduction of the patient's symptoms. So how far should you take a tension test? It should be no surprise that stretching a nerve to its limits would produce an undesired neuroresponse, meaning numbness, tingling, a shooting sensation, or really, it just doesn't feel good. There are studies that have examined the use of range of motion measurements to develop a cutoff point to limit false positive testing, as patients who are asymptomatic still develop a neurosensory response during testing. These results should be utilized with patient values because there is a possibility that a patient's range of motion may be limited and not cause neurological symptoms without any neuropathy present. These range of motion cutoff scores should be regarded with speculation, as further research needs to be done to confirm their use in clinical practice. The Upper Limb Neural Tension Test 1 is the most commonly used test. It combines scapular depression, shoulder abduction and external rotation, elbow extension, forearm supination, wrist and finger extension, and cervical lateral flexion, first away and then toward, to include a structural differentiation. The test is considered positive when neural sensations occur during elbow extension and when symptoms are reduced when the elbow is extended and the C-spine is laterally flexed towards the affected limb. Sandsmark and Nissel determined the sensitivity to be 77% and the specificity to be 94% in patients with neck pain, though Weiner determined a low specificity of 13% in patients with carpal tunnel syndrome, which is consistent with Davis's findings of a false positive rate of 86.9%. Hines reported poor inter-rater reliability when examining resistance to movement rather than patient response based on structural differentiation. Davis determined a cutoff range of motion measurement for the Upper Limb Nerve Tension Test 1 to be 60 degrees of elbow extension. In the Upper Limb Nerve Tension Test 2, pain and range of motion should be reassessed with each individual movement. The clinician depresses the patient's shoulder with their thigh, and the elbow is grasped with the clinician's cranial hand and the wrist with the other hand. The shoulder is then passively internally rotated, and the elbow is placed into extension and the forearm pronated. This position is maintained as the examiner's hand that is grasping the wrist descends to extend the thumb and fingers. The patient is then told to laterally flex the C-spine away from the tested limb to determine production of symptoms. A specificity of 93% has been found. Then the patient is told to laterally flex the cervical spine toward the affected limb to decrease the symptoms, where a sensitivity of 70% has been found. The lower extremity nerve tests include the SLUMP tests. The SLUMP test is thought to assess the sensitivity of nerve roots, including the sciatic nerve and the tibial nerve. The patient sits on the edge of a table in a slumped or slouched position, flexing the thoracic and lumbar spine. Then they are asked to flex the cervical spine by bringing their chin to their chest, followed by knee extension of the affected limb and dorsiflexion. Positive test is determined by a structural differentiation. Extending the cervical spine reduces symptoms. In Stankovic's study of patients with spinal disc herniations, the sensitivity of 83% was found and a specificity of 55% was noted. Gabb found in the inter-rater reliability to be 0.95, while inter-rater reliability was 0.92. Alterations of the test can be performed to perform the distal actions first, so dorsiflexion, progressing to cervical flexion, and then extension of the knee. The order in which the test is performed is believed to influence the direction of the neural glide. This may also affect the reproduction of the patient's symptoms. According to Davis, after studying an asymptomatic population, the false positive rate for the SLUMP test is 33.3%. This finding is also supported by Coulart. Davis determined a cutoff range of motion measurement for the SLUMP test to be 22 degrees of knee extension. The femoral nerve tension test starts with the subject lying prone, and the knee is passively flexed while the hip and thigh are stabilized. This can be better accomplished with a bolster under the affected thigh. These results should be taken with caution, as the musculature on the anterior thigh is also being stretched. There is currently not any injury diagnostic data on the utilization of this test. The straight leg raise is also a lower limb tension test that can be used. The patient is asked to sit on the edge of an exam table. The affected limb is then passively stretched by passively flexing the hip. Hip internal rotation, hip adduction, and ankle dorsiflexion can be performed to increase the tension. The test can also be performed supine, and passive flexion is provided to the hip. These tests are, of course, only a measure to determine further need for diagnostic tests through magnetic resonance imaging or treatment and/or possible surgery. Neurodynamics is a complex area of evaluation and diagnosis that will continue to be explored and researched throughout the course of treatment to neuropathy and injuries to the lumbar, thoracic, and cervical spine. Thank you for taking the time to view this presentation. I hope that you gleaned some information watching the presentation as I did creating it. Of course, if you have any questions, you can contact me at the information provided at the bottom of this video.